I am Dr. Nasmani, and this is the sixth part of the ECG analysis of Pediatric ECG. Hope that you have enjoyed the previous sessions. Now we stopped with the calculation of cardiac axis in the previous session. So just start from where we stopped. Normal axis, lead 1 will be positive and lead 2 also will be positive, but in lead 3 it may be positive or negative. If there is a case of right axis deviation, lead 1 will be negative and lead 3 will be positive, but in lead 2 it may be positive or negative. In the case of left axis deviation, lead 2, 3 will be negative and lead 1 will be positive as far as your QRS complex is concerned. And this is based on the principle that the direction of current flow is towards the lead if there is a positive deflection. When the flow is away from the lead, there will be negative deflection, and if the lead is 90 degree to the flow, the QRS will be equiphasic. So choose the limb lead close to being equiphasic. The axis lies about 90 degree to the right or left of this lead. With reference to the x-axial diagram, inspect the QRS complex in the lead adjacent to the equiphasic lead. If the lead to the left side is positive, then the axis is 90 degree to the equiphasic lead towards the left. If the lead to the right side is positive, then the axis is 90 degree to the equiphasic lead towards the right. So that's a picture showing the x-axial diagram, and you can see that the lead 1 is 0 degree, and the 30 degree corresponds to the negative part of AVR, 60 degree corresponds to the positive part of lead 2, 90 degree corresponds to the positive pole of the AVF, and 120 degree corresponds to the positive pole of lead 3, and the AVL corresponds to the minus 30 degree, the positive pole of is there. So from these, by knowing this, you can very well find out the axis. So just to memorize, I will say from minus 30 positive of AVL, 0 is the plus 1 positive, minus plus 30 is the negative pole of AVR, then 60 is plus pole of positive pole of 2, 90 degrees AVF, 120 is positive of 3, and 150 is negative of AVL. So lead 1 AVR, 2 AVF, 3 AVL, 1 AVR, 2 AVF, 3 AVL. That is the sequence in the clockwise direction. Determination of cardiac axis during the x-axial diagram is shown on your left panel. Lead 2, that is 60 degrees, is almost equiphasic, and therefore the axis is 90 degree to this lead, that it is mean 150 or to the right or minus 30 to the left. So that is you get by adding 90 to 60 or subtract. Examination of the adjacent lead, that is lead 1 and 3, shows that lead 1 is positive and the cardiac axis is therefore lies at minus 30 degree. Now this picture shows the mechanism of ventricular node reentrant tachycardia, showing the slow and faster conduction route and the final common pathway through the lower part of the AV node and bundle of His. I am showing in the figure the AV node, the fast pathway on your right side, the His bundle is the common, and the slow pathway on the left side, and the break is shown just to tell that it has not been conducted upwards. And in this picture on your left side, atrial beat which is premature is conducted down, and the discussion will come. Anyhow, follow the picture. You can see that fast path it is blocked because it is refractory, and on the left side you can see the slow path conducts the impulse and it comes down. And on the right side you can see that from the slow path the impulse goes through the fast path in the reverse direction because the fast path has recovered. So the description is that premature atrial impulse finds the fast path refractory, allowing conduction only down the slow path that is on the left side. By the time the impulse reaches the His bundle, the fast path recovers, allowing retrograde conduction back up to the atria. The resultant circus movement gives rise to slow fast AV nodal reentrant tachycardia, that is shown on your right side. Idioventricular nodal reentrant tachycardia is the most common cause of paroxysmal regular narrow complex tachycardia. Narrow complex tachycardia. Affected individuals are usually young and healthy with no organic heart disease. Mechanism of this AV nodal reentrant tachycardia is in AV nodal reentrant tachycardia there are two functionally and anatomically different distinct pathways in the idioventricular node with different conduction velocities and different refractory period. They share a final common pathway through the lower part of the AV node and bundle of his. One pathway is relatively fast and has a long refractory period. The other pathway is slow with a short refractory period. In sinus rhythm, the atrial impulse is conducted through the fast pathway and it depolarizes the ventricle. The impulse also travels down the slow pathway but terminates because the final common pathway is refractory. The slow pathway has a short refractory period and recovers first. An AV nodal reentrant tachycardia is initiated, for example, if a premature atrial beat occurs at the critical moment when the fast pathway is still refractory. The impulse is conducted through the slow pathway and is then propagated in a retrograde fashion of the fast pathway, which has by now recovered from its refractory period. Thus, a re-entry through the circuit is created. The ECG findings during sinus rhythm, the electrocardiogram is normal. During the tachycardia, the rhythm is regular with a narrow QRS complex and a rate of 130 to 250 beats per minute. Atrial conduction proceeds in a retrograde fashion, producing inverted P wave in 2, 3 and AVF. However, since atrial and ventricular depolarization often occurs simultaneously, P waves are frequently buried in the QRS complex and may be totally obscured. A P wave may be seen distorting the last part of the QRS complex, giving rise to a pseudo S wave in the inferior lead and a pseudo R wave in lead V1. The ventricular tachycardia is defined as 3 or more ventricular extrasystoles in succession at a rate of more than 120 beats per minute. The tachycardia may be less terminating but is described as sustained if it lasts longer than 30 seconds. The term accelerated idioventricular rhythm refers to ventricular rhythm with the rates of 100 to 120 beats per minute. Ventricular tachycardia is described as monomorphic when the QRS complex have the same general appearance, and polymorphic if there is wide beat to beat variation in QRS morphology. Monomorphic ventricular tachycardia is the commonest form of sustained ventricular tachycardia. Now, bundle branch block. It's common in children, but myocardial infarction also needs some mentioning here. So, acute myocardial infarction in the presence of bundle branch block carries a much worse prognosis than acute myocardial infarction with normal ventricular conduction. This is true both for patients whose bundle branch block precedes the infarction and for those in whom bundle branch block develops as a result of acute event. See, in Down syndrome, children may have AV canal defect and also they develop something like progeria and myocardial infarction type pattern. So that is important in children. Thrombolytic treatment produces dramatic reductions in mortality in adult patients, but we don't do in Down syndrome. And the greatest benefits are seen in those treated early. It is therefore essential that the electrocardiographic identification of acute myocardial infarction in patients with a bundle branch block is both timely and accurate. Now, something about left bundle branch block. Left bundle branch block is most commonly seen in patients with coronary artery disease, hypertension or dilated cardiomyopathy. The left bundle branch usually receives blood from the left anterior descending branch of the left coronary artery and from right coronary artery. When new left bundle branch block occurs in the context of an acute myocardial infarction, the infarct is usually anterior and mortality is extremely high. The electrocardiographic changes of acute myocardial infarction can be difficult to recognize when left bundle branch block is present, and many of the conventional diagnostic criteria are not applicable. Abnormal ventricular depolarization in the left bundle branch block leads to secondary alteration in the recovery process. Now we have talked about bradycardias and atrioventricular conduction block. This appears on the ECG as repolarization changes in a direction opposite to that of main QRS deflection. There is appropriate discordance between the QRS complex and ST segment. Thus, leads with a predominantly negative QRS complex show ST segment elevation with a positive T wave. an appearance similar to that of acute anterior myocardial infarction. Recognition of acute ischemia. Many different electrocardiographic criteria have been proposed for identifying acute infarction in left ventricular branch block, but none has yet proved sufficiently sensitive to be useful in the acute setting. However, some features are specific indicators of acute ischemia. ST segment elevation in association with a positive QRS complex, or ST segment depression lead V1, V2, V3, which are predominantly negative QRS complex, is not expected in uncomplicated left ventricular branch block and is termed inappropriate concordance. Inappropriate concordance strongly indicates acute ischemia. Extreme ST segment elevation, that is equal to more than 5 mm in lead V1 and V2, also suggests acute ischemia. If doubt persists, the serial electrocardiogram may show evolving changes. Now, I hope you enjoyed the session. New editions of ECG tutorial will be posted in www.youtube.com/acpgmet. I am Dr. Nasmani. Goodbye.